everyone. I will be sharing the experience from South Africa's first participatory surveillance platform for influenza-like illness and COVID-19, and how we've also linked eligible participants to home-based testing. So the Center for Respiratory Diseases and Meningitis runs a number of sentinel surveillance programs. We have 3 active ones. The first is for influenza-like illness, which spans through a network of public clinics and general practitioners. We also have pneumonia surveillance, which spans through public hospitals. In all of these programs, we test for influenza, respiratory syncytial virus, COVID-19, and pertussis. All right, so 75% of symptomatic cases are not medically attended in South Africa. Testing capacity and access to primary care is also limited, and all of these lead to a potential gross underestimation of the community burden of respiratory illnesses. So our aim was to pilot the methods of participatory surveillance in our setting, to link eligible participants to home-based testing, and to use participatory surveillance to complement already existing sentinel surveillance. So our platform is called CoughWatch SA and is open to all South African residents who are 18 years and above. Our platform is zero-rated, which means our participants will not incur any mobile data expenses, and eligible participants are then invited to participate in the home-based testing. So home-based testing, called CoughCheck, is a pilot that was launched last year and ran until August this year. Participants may request for a testing kit to be delivered to their homes, and then these are tested at the lab for PCR confirmation of the same pathogens. The results are then SMSed to participants within 24 hours. We also do characterization of the influenza and RSV pathogens, and there's potential to do real-time genomic sequencing from this data through our lab. So 2 things to note about the results is that they are preliminary based on our current pilot, and that we were statistically underpowered in terms of numbers. So the purpose is to show the potential value of this in our setting. Okay, so this figure shows you the total number of enrollments and the weekly proportion of active participants and how this fluctuated over time. So despite rigorous and various communication strategies, we really struggled to increase the participants beyond the 249 numbers. So the majority of our participants are in the age group of 30 to 39 years old. A majority of them were women. And in terms of vaccine coverage for influenza and COVID-19 vaccine, we saw a higher proportion compared to our sentinel surveillance. So this shows you a figure of the cumulative number of symptoms reported. So the title slide is incorrect, but cough and sneezing were one of the highly reported symptoms, and fever was one of the least reported symptoms, which made us consider a case definition of ILI with and without fever. So this shows you the epicurves of the weekly number and proportion of reported cases from CoughWatch SA, and comparing this to the weekly proportion of ILI consultations from Netcare, which is private consultations from South Africa. The orange line shows you the weekly rates of ILI consultations, and the black line shows you the weekly purported cases of CoughWatch SA. What's important to note is that we were able to track the signal of ILI consultations at different parts of the deployment, despite the enrollment numbers being low. This figure shows you a similar picture, but based on COVID-19 cases. And similarly, we were able to track the trends from the ILI consultations at different parts of the deployment, despite not having the significant numbers that we were hoping for. So the correlation between the proportion weekly reported cases and the proportion weekly ILI consultations, we found that the suspected case definition for ILI with and without fever had a small correlation, and COVID-19 had a moderate correlation to the ILI consultations. In terms of home-based testing, 36% of our participants were eligible for enrollment, and 92% of those were successfully enrolled, which shows how the linkage actually worked. We were able to detect 7% of influenza, a case of RSV, and 32% of COVID-19 cases from our cohort. So overall, participatory surveillance may be useful for low to middle income countries to address some of the limitations of sentinel surveillance. Effective and consistent communication strategies are essential to drive and sustain the enrollment numbers. We also found that the trends from participatory surveillance are comparable despite the low enrollment numbers, and that home-based testing may provide the specificity in terms of lab confirmations that is often lacking in participatory surveillance. I'd like to acknowledge my supervisors, of which one of them is in the audience, Daniela, the entire NICD team, and our partners and funders who made the study possible. Thank you.